Good afternoon, everybody, and welcome to the academic program today. I was still waiting some more people to come, but it's time now. It's time to begin. The topic today, say again? Yeah. Yeah, the topic today, first of all, let me sort of thank Lundbeck Pharmaceuticals for providing me with some slides which form the backbone of this presentation. However, I have updated their slides with some extra material. This topic is relevant to most people, the nurses, psychiatrists, doctors, and the pharmacists, because this is an issue which is coming up day in and day out. So it's important that we keep abreast of the improvements or the developments in this field. So if you are attentive during the whole process, you will have two major teaching points. One is the recognition of the psychopharmacological viewpoint or options in managing the acute psychiatric conditions. And second is the recognition of the management of the chronic or the ongoing psychiatric violent conditions. And in addition to it, we'll also be discussing briefly the psychological management to an extent, because which forms one part of the management of the violent behavior. We do not jump to give medications to somebody. We basically train to use the psychological techniques, which we'll be discussing as well. So anyway, we'll be skipping the slides. These are the previous questions. Outline. Today we'll be discussing mostly these are the areas that we'll be focusing our discussion on. First one is the definition. What is violence, aggression, and these related terms that often are confusing, often used synonymously. It's important that we know their exact meanings. Epidemiology, how prevalent the condition is in inpatient, outpatient communities. Etiology and assessment, what that we know of recently about violence, and how do you go about assessing the condition before we jump to management. And management, again, divided into two parts, acute management as well as the management of the chronic or the ongoing psychiatric conditions. Agitation. Anyone can define what agitation is? I wanted to make it as interactive as possible. Any definition will do. Any volunteers? What an agitation mean? Violence. Okay. And what violence means in layman terms? Yeah, I think more or less similar. See, agitation classically defined in the psychopathological text as an excessive motor or verbal activity. That's agitation. Both psychological as well as physical components are there. Aggression, on the other hand, is any behavior that can result in both physical and psychological harm to oneself or to others or to the objects as well. It can be verbal, physical, against the objects, like say furnitures, or against people. So when it is against people, we call it as violence. So this is physical aggression by people against another people, someone else. It's called violence. Hostility, again, is a loosely defined term. More often, it means the same: aggression and irritability, suspicionless. It's important to keep this definition in the mind so that we know when you are referring to these terms again and again. So there are different types of aggression we talk about. For our perspective, it will suffice to discuss that the aggression could be two types, primarily the hostile aggression and instrumental aggression. Instrumental aggression is done in order to get something in return. Hostile is more driven by the inner cues. There is no necessarily external incentives for that. So let's have a look at the next slide, the violence in the community. So this is talking about prevalence of violence in the community. A famous study, many of you might have heard about it, ECA, Epidemiologic Catchment Area Study in USA. Lots of important figures about epidemiology are derived from the study. So about violence, we know that they studied almost Out of 20,000, 50% responded, around 10,000 people they studied, and they found that violence is around 5 to 6 times more common in people having mental illness compared to those without. So we can safely tell that as a group, people having mental illnesses are slightly more violent than others. But the other extremities we'll be discussing, there are some caveats. It's not necessarily all type of mental illnesses. The next slide will be telling us a bit more about that. Quite a colorful slide. So as you can see, the violence in community without any mental illnesses, say around, as you can see, quite a minuscule. But when it comes to the other extreme, anxiety, affective disorders, schizophrenia, substance abuse, and mental disorders and substance abuse combined, that group, which tops the list. So hovering around, say, 22% people are violent in that group. So it is more so, it's not all mental illnesses, it partially skewed towards the diagnosis of substance abuse and mental illness comorbidities. That's what I have mentioned here. So etiology of the violent behavior, we can summarize it by telling that it is multifactorial. That basically means that it is a substance abuse, dependence, intoxication, and various disease processes could be contributing to it. Neuropsychological conditions like, say, impulse control or cognitive impairment can also contribute to it. And underlying character pathology, very often possibly that comes up much before anything else. For example, a person who is antisocial or aggressive, that's a way of communication for them. And chaotic environment, for example, a busy OPD, we do not know what the person is wanting, and we do not listen or hear him. So at the end, he gets excited, he gets upset. So assessing the violence, the initial part, we talk about the medical conditions which can contribute to violence. There's a huge list, as you can see. In our sort of undergraduate, postgraduate days, used to remember as inflammatory, neoplastic, metabolic, infective, and various other causes. So they are all grouped under different headings. So patient management, again, coming, first assessment is the first part of the management, is rule out the somatic conditions, physical conditions, because that could be masquerading as violence, whereas there is a potentially treatable illness, something else we are dealing with. One can sort of argue that it's difficult sometimes to examine a person when he is excited, but whatever is possible, even observation is very important. Otherwise, especially in the elderly group, if you jump and manage the person without diagnosing and person dies, will be in deep trouble, medico-legally. Comorbidities, particularly with the substance abuse and personality disorders, we discussed about that. Then the adverse drug effects, akathisia. Anyone who can define what akathisia is? Probably our the psychiatric or nursing colleagues can tell. All right. I mean, well, you probably mean it's a tardive dyskinesia. No, I mean, akathisia is more of a acute onset, and usually, sorry, you're saying something, Dr. Rath, I interrupted.
Physical and mental restlessness.
Exactly. That has been defined as physical and psychological restlessness. Okay, and usually that appears in the beginning of the antipsychotic treatment, and with some other psychotropics as well. The mechanism is not clear. Some people believe is until the neurotransmitters get adapted, that happens. So when you change, increase or decrease the medications, akathisia might occur. This is important because some people are driven to commit suicide when they're akathisic. So just answer is not to increase the medicine and give them more akathisia, just to realize it is a possibility. There are various modes of treatment of akathisia. I will not discuss with that. I mean, like say propranolol and benzodiazepines have been used. Did I miss the last one? Okay, but this assessment, risk assessment, should be the basis, or say physical assessment of a person is a basis on which, in other words, I'm just trying to sort of find the right words. It is basically under the umbrella of the risk assessment, we should see the person. The person that we see is aggressive should not be seen just at a cross-sectional level, because there are various other factors from past to his constitution to what's happening to the environment. All things contribute to it. A very quick sort of way of recognizing or assessing violence would be like, always look for, is there a current plan and what are the available resources available. So we call that CPR, current plan and available resources. This is the aggression cycle. I want you to have a look at this one, particularly the psychologist. Here, we believe that aggression is a bit like explosion, but if you look carefully, there is something that precedes the aggression and something that succeeds aggression. So the phase that precedes the aggression or the agitation is called the escalation phase. It gradually gets more and more until it explodes, almost like a time bomb. So it's important to realize or to recognize those features or the so-called escalation phase. The whole therapy of de-escalation, there is a slide, next one we'll be discussing about that, is based on that. So we prevent the person from escalating and reaching that explosive phase. Once explosion comes, the person is in a crisis, your psychological management may not be as effective. Probably you need to restrain him either physically or chemically. So that's very important. And also following that post-explosion phase, we almost don't recognize this phase. Very often what happens, people are depressed, they are guilty, they have lost financially, and a lot of consequences or sequelae that occurs. So it's always important for the person who is aggressive should be knowing this diagram. Very often it's a famous diagram in the anger management courses. De-escalation, as I was talking about, consists of a group of behavior, both on the part of the clinician as well as the nearby people, in which they purposefully establish a relationship with the client to diffuse the tension, to prevent him from going to that explosive stage. So that's the main aim of de-escalation. As you can see, recruiting family and friends is also an important aspect of it. And very important thing, the last point, it's important to ascertain what the patient actually wants and at what level of urgency. All he wants, possibly in our setup, maybe one drug. He wants, okay, give me the certain addictive drug, then it will be all that I want. Or he wants some sort of his demands to be met and he doesn't know how to express it. So that's basically, that forms one of the core features of the de-escalation technique. And it's important from our perspective because knowingly or unknowingly, many a time, we escalate people. Even if they are not as escalated, we do that. So it's important to reflect whenever a person has behaved in a particular way. Next one. The overview of the acute violent management. Here we're talking about there are multiple factors. The environmental interventions forms a very important aspect of the management, like say restraining, seclusion, calming blanket. Very often you use to overpower a person. That's called as calming blanket. I don't know why. It's called calming. The person is not very calm at the end of the day. So the non-specific sedating agents should be considered earlier than later, so that the person doesn't escalate to the aggressive phase or to the explosive phase. We'll be discussing a bit about, in fact, quite a bit about LORAZEPAM and antipsychotics in our discussion. So the goal of the acute violence management, as you can see, is to calm the patient, to decrease the likelihood of harm to self or others. You must allow the person certain diagnostic tests to be performed, to attenuate or to diminish the psychosis, decrease the need for the restraint and seclusions. See, it is not sleep. We do not want the person to be asleep. We want them to be sedated so that we can do certain things, we can work with them. When they are sleep completely, it will be difficult basically to do an interview and we have to wait until the person wakes up. So the pharmacological management consists of multiple medications, as you can see, range of antipsychotics, mood stabilizers, antidepressants, anxiolytic, beta blockers, you name it, it's there, has been used in the acute management of violence. So let's go one by one. Olanzapine IM, the prototypical anti-aggression agent in the community, in the acute setup, in the emergency setup, many people use. It's been evaluated. There are multiple randomized double-blind placebo-controlled trials, particularly violence associated with psychotic conditions like schizophrenia and bipolar illness. They are more responsive to olanzapine. Its superior onset in efficacy, as you can see, to haloperidol and LORAZEPAM. And there is no significant adverse side effects except compared to the haloperidol and LORAZEPAM again. I mean, there are like issues with sedation, hypotension, which have been talked about, especially when you give to a vulnerable person. Favorable EPS, extrapyramidal side effect profile. Weight gain is not our main concern in the short term. However, that must be kept in the mind in the long run. LORAZEPAM. Unfortunately, both LORAZEPAM as well as olanzapine are not available in our setup in the emergency at this point in the time, but most parts of the world it is available. This is a non-specific, it's one of the drugs of choice for non-specific sedation, especially when we are not clear about the diagnosis, which often happens in the acute emergency setup. And they are rapidly absorbed intramuscularly. That's one advantage compared to diazepam. Sometimes it could be a bit tricky. And it also, they don't have any acute metabolites, as we know. And the major drawback in the prolonged use, like with most of the benzodiazepines, we have to be careful about the dependency potentials. Very unlikely with the injectable preparation though. Another very potentially effective combination we do not use for some reason in this part of the world is the haloperidol and LORAZEPAM combination. We often jump to haloperidol and phenergan duo, but this is very effective. They tell it is, in fact, the Maudsley guideline talks about it as being more effective than haloperidol and phenergan combination. So for some reason, we are using phenergan and haloperidol, and decrease extrapyramidal potentials compared to haloperidol alone. And the good news for the nurses is that in the emergency setup, it could be given in the same syringe. The small tip, but that means a lot when we are dealing with where minutes and seconds are important. Cost. I talked with our pharmacist Mirasik, sent me some of those local costs in dirhams as well, but I didn't get all the costs that I put it in the American dollars. As you can see, there is a cost difference among various medications, but what is important, the side effects and the efficacy. So as they call, as they discuss in some of those advertisements you might have heard, the importance of avoiding acute dystonia and akathisia are priceless. Okay. So drugs which are not indicated in the acute management of the violence, it's from the NICE guideline, latest one, which possibly was reviewed only a couple of years ago. Injection chlorpromazine has no place in acute management of the violence. So also injection diazepam IM, we had some discussion about that, but this is what the position of NICE guideline. It doesn't mean that we cannot give it, but that's what the recommendation is. Injection thyroidazine, IM depot antipsychotics, and it's important to know this IM depot antipsychotic. The other day I was discussing with Dr. Amal. Somebody by mistake gave this IM as IV. That was a depot antipsychotic, like say Acufase. So that could land us in trouble. Usually we do not use those depot in the short term, even if they are the Acufase type. The minimum duration before they fully active are 10 to 12 hours. So they have no role in the acute management. Persistent management is another issue. I would like to draw your attention to the last point. Olanzapine and risperidone, and in fact, for that matter, most of the atypical antipsychotics should be used very cautiously in elderly people, especially people having dementia, because of its link with cardiovascular death and particularly stroke. And this is, I think they have got a black box warning in the FDA. So unless you have to use, be careful using the atypical antipsychotics in elderly people. Possibly think about LORAZEPAM or other benzodiazepines. So in summary, violent and threatening behavior is a frequent reason for admission to the hospitals, as you can see and appreciate. And the newer formulations, the second generation antipsychotics, have got several advantages over the typical antipsychotics, and especially they require acute interventions or who refuse the oral antipsychotic treatment. Now coming to the next topic is the long-term management of the violence. Because very often we are left with not one single episode of violence, more at the inpatient setting, the multiple episodes, the person who remains persistently violent. There, the sedation alone is again not important, not adequate. It's probably important for the short term, but not for the long term. The primary treatment here, the antipsychotic medication is inadequate, treating of the primary underlying problems. So that's the issue. For example, a person who is not improving so far as the psychosis is concerned, we cannot focus more on the anti-aggression. So many a time, psychosis and aggressions are linked. Although some medicine could be specifically working as more anti-aggressive than antipsychotic. So that's the point. So those two features are not always, they don't go parallelly. And the importance of remembering the basic mechanism of impulsivity is something to do with the serotonergic system. This is a bit complex diagram which talks about the causal pathway of the aggression in the schizophrenia in particular. As you can see, there are predisposing factors leading to psychiatric disorders, manifesting psychiatric symptoms, and ultimately, with these stressors coming here, they result in the aggressive behavior. Something that we are discussing about the escalation phase. So before aggression occurs, there are a lot of things they have to go through. So that also gives us opportunity to use our technique, or we can intervene at different levels. So treating the patients from the beginning, say the psychiatric illness has an importance, so also other parts. The persistent aggression, the psychopharmacology. Second generation antipsychotics have been talked about a lot. Mood stabilizers, particularly lithium and carbamazepines, and other anti-epileptic have also been, we'll be discussing a bit. Beta blockers. Very often we ignore that very important psychotropic in our psychiatric practice, in our day-to-day practice, that has got an established role in aggression management, especially in the long run. SSRIs, we discussed about the antidepressants, they are also important. Benzodiazepines, in fact, they have summarized it in the long run. They are mostly not very effective. Doesn't mean that we'll not be using it, but in the long run, they have limited role. So, coming to the clozapine, it is backed by a number of retrospective reviews as well as very respected studies that in aggression, even in the acute as well as chronic aggression, it has got an established role. So much so that it has got FDA approval for using in chronic persistent aggression. Risperidone is effective, although the data may not be as much as clozapine. Olanzapine, there are a few NIMS studies, they found that post-hoc analysis is effective, is possibly more effective than haloperidol. Quetiapine, the Seroquel, Ziprasidone also they have been tried and useful. So also Abilify, in fact it has found its place last, but most of the literature, including the Maudsley guidelines, talks about Abilify being effective so far as the psychotic symptoms are concerned, but for aggression, it has got limited efficacy compared to most of the other medications. So you have to keep that in the mind, in the sense that many a time aggression could be part of the psychosis. Well, fine, but many times it may not be the case. So Abilify stand in that way, Abilify probably will be falling behind. So clozapine, olanzapine, different variables. I'll not be going into detail of these slides. They have used PANS to measure the effectiveness of these things. So PANS hostility items, where they have used the last observation carried forward. That basically means that when people left the study in between, they continued the study as if they were there. So they found that, as you can see here, baseline on 40 weeks, clozapine has got a significant improvement compared to haloperidol. In fact, there is a worsening of the condition, as you can see. Long-term use, so far as the hostility score is concerned, primarily. So in summary, second generation antipsychotics, clozapine has got the strongest evidence, backed by multiple NIMH-funded randomized controlled trials. Risperidone has got conflicting evidence, although we often use it. I'm just reading the summary lines. Olanzapine, as I was telling before, is better than haloperidol, but not as good as clozapine. Seroquel, quetiapine, its selective effectiveness on the hostility, but possibly it could be better than haloperidol, but not as much compared to other medications as I discussed. Abilify in the post-hoc analysis has got specific anti-hostility effect, okay, and superior to placebo, but may not be comparable with our typical haloperidol. So that's the take-home message. Ziprasidone has also been used. So adjunctive mood stabilizers, which has been used in violent situations, particularly people having mood disorder or say psychotic conditions. Lithium has got lots of evidence, but at the end of the day, they have the author has sort of concluded that they're probably not as effective on their own. Carbamazepine has been sort of used, as you can see. Most of the mood stabilizers has been studied, but what stands clearly is that we'll be discussing the next slide about valproate. Just coming to that, valproate. In fact, here they talk about expert consensus. Not necessarily there are a lot of studies done on the effectiveness of valproate, but valproate is more frequently used depakine-clono in the violent situations. So adding valproate in people having substance abuse tops the list who have become violent than the other way around. And as I told, there are only a few sort of studies, and there is moderate response rate of valproate. Beta blockers, as I discussed, I sort of summarized the whole thing in only one slide. The anti-aggressive effect are suggested by many case reports and are confirmed by 3 control studies by that time. As you can see, the review was done sometimes like almost 10 years ago. So that's probably not as representative of what the situation is right now. The effects are reported for a broad spectrum of psychiatric disorders. The onset of the anti-aggressive effect may be delayed. So 4 to 6 weeks, you might have to use propranolol before you get its efficacy. So dose-limiting adverse effects include the hypotension and bradycardia. The mechanism of the anti-aggressive effect is not very well understood. We do not know how it affects, but specific efficacy, as I was talking to you, it has been tried in akathisia. Antidepressants, particularly here, fluoxetine and citalopram, especially with personality disorders or underlying dysthymia. Many times irritability is one of the symptoms in that group of patients. Benzodiazepines. Here probably the literature is more or less conclusive. They mention that there is in fact negative evidence on the long-term use of benzodiazepines. Short-term, well, you might justify for a while, but long-term, you have to be really careful. And besides, like lorazepam we talked about a lot, but that also is one of the problems, the withdrawal, especially when you tend to use it very frequently. So in summary, treating the underlying disorder is important. Clozapine more effective than first generation antipsychotics, reducing the aggressivity in schizophrenia, and is clearly superior to risperidone and olanzapine, as we found out. Adjunctive valproate is commonly utilized, but certainly we need more research, more reports on these things. In contrast to all those things, all the mood stabilizers have been very much studied, obviously, in the bipolar disorder. Beta blockers is well studied in the brain injured patients, again, in addition to akathisia I was talking to, and may be helpful as an adjunctive agent in aggression in schizophrenia. So this is the only slide possibly you have to take from the whole presentation. It will be, that's it. So unagitated patient comes, so both simultaneously we have to look at pharmacological as well as non-pharmacological ways of handling it. Environmental manipulations, like decreasing stimulations, remove the patient from one area to another area is important. Medication at the same time, as we discussed, offering it early is important than waiting until the last moment. Assessing importance, especially in the elderly, cannot be reiterated. And looking for substance intoxication very often as a cause of aggressive behavior is to be assessed. And also the possibility of akathisia we have already discussed, that also has to be mentioned. So if the person still remains agitated and a danger to self, you think about, in spite of all those environmental manipulations, you don't have time for medicines to work, look about seclusion and restraint. It has its own set of issues along with. And then if it's not, we'll think more like pharmacological management, like mood stabilizers and second generation antipsychotics. Medication wise, as I mentioned, if he's withdrawing from alcohol again or the sedatives, lorazepam is a clear choice because it also takes care of this withdrawal aspects. Otherwise, we'll be thinking about the second generation antipsychotics or haloperidol lorazepam combination, the one we don't use very often. So that's it. So thank you. If you have any questions, you can discuss.